pressure changes after phacoemulsification in non-glaucoma patients versus glaucoma suspects and glaucoma patients. Cataract surgery is the most common form of ophthalmic surgery worldwide. Modern cataract extraction results in short-term as well as long-term reduction in intraocular pressure. However, the magnitude and clinical significance of this change continues to be debated. This is pertinent to the patients having glaucomatous comorbidities, where the decision of combined surgery must be assessed considering the additional risk associated with it. The postoperative visual and refractive outcomes of cataract extraction have been well studied. The ability of the surgeon to prospectively predict the postoperative IOP course of patients with coexisting cataract and glaucoma undergoing phacoemulsification would greatly advance the ophthalmic care. My aim of the study was to evaluate the short-term and mid-term intraocular pressure changes after phacoemulsification with intraocular lens implantation in non-glaucoma patients, glaucoma suspects and glaucoma patients, and also to study the factors influencing intraocular pressure change. We did a retrospective analysis of 641 patients who underwent uneventful phacoemulsification over a period of 2007 to 2009 with a short-term follow-up of 3 weeks as well as mid-term follow-up of 6 to 18 months. Pre-op evaluation was done including intraocular pressure by Goldman's applanation tonometer or short-term follow-up as well as mid-term follow-up. Glaucomatous eyes were primary open-angle glaucoma, angle-closure glaucoma, normal texture glaucoma, whereas glaucoma suspects were primary angle closure suspects, ocular hypertension, and disc suspects. All the patients over the age of 40 years who underwent uneventful phacoemulsification were included in our study. Out of 641 patients, 409 were non-glaucomatous, 96 were glaucoma suspects, and 136 were glaucoma. This is the distribution of patients in my study. We had 56% male, whereas 44% females. The average age for glaucoma patients was 65.6 years, whereas for non-glaucoma patients, it was 63.3, which was statistically significant. The average intraocular pressure drop after short-term duration was 9.1%, whereas for mid-term duration, it was 12.2%, with a significant p-value. This chart shows trend in IOP reduction at short-term and mid-term, which was consistent. This chart shows different types of glaucomas having intraocular pressure reduction at the follow-ups. Here we can notice that in ocular hypertension as well as in primary angle closure glaucoma, the drop was more, that is 20% at mid-term. Our study showed that the IOP drop was more in higher age groups, as the requirement for anti-glaucoma medication was also reduced at short-term and mid-term by 23.8% and 41.7% respectively. Our study showed that the pre-op anterior chamber depth, as it decreased, the drop in IOP was more. Our study also showed that the clear corneal phacoemulsification had a significantly more drop than scleral tunnel phacoemulsification. Our study was compared with findings of similar studies conducted worldwide. IOP reduction with cataract surgery in non-glaucoma patients for short-term duration was compared with studies done by Kim et al. And Varada et al., which showed similar results. For mid-term duration, our study was compared with Singleton et al., Mathalon et al., which showed similar findings. For primary open-angle glaucoma, our study has been compared with Hayashi et al., Mercure et al., and Mathalon et al., having similar findings at short-term as well as mid-term. For primary angle closure disease, our study has been compared with Hayashi et al., showing similar results at short-term and mid-term. For glaucoma suspects also, our study has been compared with Singleton et al., showing similar results at short-term as well as mid-term. The requirement for glaucoma medication was reduced in studies like Hayashi et al. And Mathalon et al., which was consistent with our findings. Schwann et al. Showed that clear corneal phacoemulsification has more drop in IOP than scleral tunnel, which was consistent with our study. The limitations of our study was it was a retrospective study, subjected to selection bias, had a small sample size. All the measurements were taken only once by different surgeons at different timings, subjected to observer bias. Conclusion: significant IOP reduction was noted in all groups along with reduction in anti-glaucoma medications required. Maximum intraocular pressure drop was noted in angle closure disease. Conjunctiva sparing cataract surgery is a valid option in well-controlled glaucoma. Post-operative IOP control with fewer glaucoma medication improves patients' quality of life, encourages compliance, reduces expenditure, which is important in today's cost-cautious health environment. Further studies are required to understand the mechanism of IOP reduction following cataract surgery in open-angle glaucomas and also to know the magnitude and duration of this effect. Thank you.